We have Dr. Nivean Madhivanan,
Never retired.
who's an academic director, MNI Hospital Private Limited, innovator of the CM T-Flex IOL. He's the first to perform live 3D cataract surgery in South India, a specialist MICS surgeon, 1.8 millimeter phacoemulsification for cataract, a specialist in MIVS 23 gauge vitrectomy, and he's the youngest to have performed live surgery at various conferences and recipient of the Young Achiever Award. Over to you, Nivean sir.
Thank you, Prasanna, for this kind introduction. I'm just sharing my screen. Yeah. So respected teachers, senior ophthalmologists, my dear friends. So I'm going to talk about the new CM T-Flex IOL for the treatment of aphakia. Am I audible?
Boss.
Yes, sir. Audible, sir.
Sure. So as all these innovators said, the entire question comes with why. So that is how it all started. So we know for secondary IOLs, we had the Gerber-Chariot who revolutionized the externalization of the haptics, because before that we had the sutured scleral fixated IOLs. And then from that, Amar Agarwal modified the technique as the glued IOL technique. And then we have the Arvind's own system, the XNIC technique, where they externalized the haptics using the needle. And then Yamane came out with the technique where they externalized the haptic and then the cautery was done. So these were all various modifications of the existing technique using the three-piece IOL that we had. So that is when the question arises in my mind, why not have a specially designed IOL for these kind of aphakic patients? So there came the birth of the CM T-Flex IOL. As you can see, it's a single-piece hydrophilic lens with a specialized T-shaped haptics on either side. So the entire concept is based on when you bring out these T-shaped haptics out of the sclerostomies, they open up and prevent the falling back of the IOL. So just going through one case scenario, as you can see, a 360-degree subluxated lens here, planned for a lensectomy with a secondary IOL fixation. And we all know for all secondary IOLs, the key factor is the 0-180-degree marking, because that helps in the stability of the lens and the rotational thing and the astigmatism also. So we make a partial 2 by 2.5 millimeters scleral flap using a crescent blade on either side. And then 1.5 millimeters away from the limbus, a 23 gauge sclerostomy is made. The second thing done differently in this case is we did not use extra trocars because we already have these 23 gauge sclerostomies. So just used a needle to stabilize the lens, because as we are surgeons, you know that once it goes back, it becomes a whole new ballgame into the vitreous cavity. So I wanted to puncture it from the posterior aspect after cutting a little bit of vitreous, and seeing it's a soft lens, the combination of high speed cutting and vacuum. So the entire lensectomy could be performed, making sure none of these bits fall into the vitreous cavity. So this is the new CM T-Flex IOL. As you can see, the loading is into a simple normal cartridge like any IOL. So the only key thing is maybe you can put the T junction so that when you inject it, it comes out first. So these are the specially designed Sprenov forceps. You can see those broad tip. So you can grasp either the head or the neck. As you can see, the parts the neck. But at this time, we do not pull out the lens. So the rest of the lens is injected, because that can actually detach it from the body of the lens. So now the rest of the lens is just injected and the trailing haptic is kept in the wound, or sometimes you can keep it over the iris and then gently pull it out. You can see a pop sound, and then when it happens, the T opens up. So that is almost the end of one side, isn't it? So just to show you a normal animation clip. So loading is in any cartridge, and then as you slowly inject, you can see the T haptic coming out. Ideally, it will be in the head and the neck if you can catch both together. And that makes it easier when it actually comes out through the sclerostomy. And those T haptics stay in position and the flaps are closed. So moving on to the other side using the handshake technique. So you grasp the arm of the IOL design and then transfer the other haptic, as you can see here. Head on is the easiest way, because that way the T junction comes out more smoothly rather than holding the neck, even though they are very flexible lenses. So that is another advantage of the hydrophilic material here. So once that is done, that is almost the end of the surgery. You can see well-centered IOL, stable. So you don't have to do any more suturing or tucking or anything else. So most of the times we use glue, but actually glue is also not necessary. So now we have modified the technique of, instead of the flaps, we can make even scleral grooves where these haptics actually just sit under the groove. So these are some of the post-op immediate results. As you can see, day one, well-centered IOL, round pupils, because these lenses have an angulation also. So the UBM pictures in the study shows that there's no rubbing against iris or pigment release or any glaucoma that is induced because of the lens. And also some studies of OCT on how the scleral flap behaves under the IOL. So we have publications that has gone, and another 2 publications are in progress right now. And this is just to show that it is only not for a VR surgeon. Even the anterior segment surgeons can perform when you have a complication in SACS like this. You can see the wound that is sutured. So you don't have to do a full vitrectomy or the pars plana approach. You can do the same technique as a secondary procedure, like how we normally do a claw lens or any other secondary IOL procedure. So, but adequate vitrectomy is required if you can do it through the anterior approach, through the 2 side ports that are available. So just bringing out the haptics, you can see the haptic pops out and that stays there. And then the same is done on the other side. So you don't need the trocars, or sometimes you can just, if the infusion is there, you can make an AC maintainer also. You can see, and just always in the end of the surgery, it is good to check with triamcinolone astenate if there's any vitreous remaining, so you can always remove it. So I'll do it in all secondary procedures. So this is, yes, every procedure has some complications. You can have breakage of haptics that if you actually pull. So there is a short learning curve, but not very difficult. Slippage can occur when there is more force or the measurements are not right when you have large eyes or small eyes. So sometimes the measurement of the corneas and white to white is also important, as we have only standard sizes now. Late dislocations haven't been reported much at all in my case series, at least. Iritis, yes, in a very small series. So what I like to do is, like, I like to thank all the panelists who are here, because for each panelist, there's a reason that they are here. So my journey also started 3 years back when I first launched this lens in TNOA, and I did the presentation. Mohanrajan sir was the one who launched the lens. So that is the first time when I presented about this lens. Venkatesh sir was the one who came and gave me the confidence about the idea and what had to be done in a long-term follow. So that really helped me to do studies about the UBM, so to know how the lens sits, and also about, he was very particular on how the scleral flap behaves, because it is kept outside and whether there'll be any erosions. And then when the next year when I presented in All India, I think I had a breakfast session with Suvin sir, and he was very nice enough to tell me about the importance of patency, because these are all other youngsters who are presented. So it is how to take your innovations forward is the most important key step after the innovation. So he really told me about the difficulties and what has to be done to get it patented, because he had done it for the BHEX and he did it all by himself, and how it is successful right now. So that was again a very big learning curve for me. And then moving on, JK sir has always been an inspiration, because he's the one, he helped me work with the InFocus lens, and he's the sole inventor of the InFocus, which he doesn't tell outside. So he really helped me in saying how to get to the A constant and how to actually make the design simpler. We had a more bulkier design, and then we actually did some modification in the parts of the lens to make it actually simpler and easier to use. And then I was there lucky enough to share the session with Kumar Doctor sir, and he had come out with a lot of questions to me on that day, which I didn't have answers for, even from the diameter of the hole that was there.
The Gurgaon conference.
Also, the thickness of the T-junction. So he actually told me like how you can make it actually flatter, so it easily comes out through the 23 gauge sclerostomies, and then it is not bulky, or post-operatively you don't see that bulge in these patients. So all these things made me think, and every time make constant changes, because invention is not the key thing. Then to continuously do and make sure it is sustainable in the long run, and it benefits the patient. In the end of the day, as clinicians, I think whatever innovation we do, it should be beneficial to the patients, and that is how they've all helped me in this journey here, the entire panels. So thank you once again, TNOA, Mohanrajan sir, for giving this wonderful opportunity, John, for including me in this, and thank you once again.
Fantastic. I don't know, Kumar, you had a lot of questions during our session.
I know, sir. I didn't have answers that time.
Gurgaon conference when we presented, and we were asking, we were on the dais together, and we are also concerned about the size of sclerotomy, and also the haptic staying outside, whether there will be any erosion or something like that. So that is one concern which we had. So till now we have not had any case of.
No, sir, no exposure. So we slowly moved on to the groove actually. So
that's a good idea, Nivean. Taking a tunnel, rather than a flap. Instead of flap, you take a tunnel and just pull into the tunnel. Nicely, it looks very nice.
Yes, sir. Simpler also.
Nivean, one question: What forceps are you using? You're using a VR forceps for that? It's a vitreoretinal forceps.
I've actually designed 2 forceps, sir. So one thing is to grab the haptic that only the tip alone is broad.
Yeah,
Because
I
other
got
forces
that.
sometimes
I
are
saw that. It
sharp.
was a much flatter one.
Correct, sir.
But what I'm asking is, what's the length of the stock? Is it the standard VR forceps?
Yeah. The other measurements are the standard VR forces.
Yeah. So there, I would give you a small tip. I mean, because you're a retinal surgeon, you're using a VR forceps, and actually, it's counterproductive. Use a shorter stock length, 15 to 18 millimeters, because you don't need that much of length. The longer VR forceps is actually unwieldy over there. You're not going into the posterior segment at all. You hardly go. I mean, you just need to grasp that T and bring it out. You don't need anything more than 15 millimeters. That will make your forceps handling much easier.
Yes. Maybe 10 to, maximum you need 10 to 13 millimeters.
That's why the BX forceps is also there. You have VR forceps, but I've damaged all my VR forceps doing that. So then I made it a shorter one. So I damaged a few. I started off as a VR surgeon, so I have damaged all my VR forceps for that. So you can make it shorter. It's much more wieldy, in the anterior chamber.
And handling in anterior chamber is easier also.
Yeah.
You can use the glued IOL forceps, which is made by the Epsilon. Yeah.
Yes, sir.
That also can be done. That grabs very well also.
Correct, sir.
Another thing is, do you have the different sizes, Nivean?
Lenses as of now, no, sir. Only standard lenses. So ideal corneal diameter anything between.
What about high myopes and all? You find it difficult, no?
We had this question a lot. Right now, we have done only 2 cases where we have made the sclerostomy slightly closer. And also we can go vertical if the vertical diameter is less. Hypermetros, we can go up to 2 millimeters. So we're only altering the length of the sclerostomy right now. But they said if at all we have extreme eyes, the lens can be customized. The whole problem is getting a mold to make a different size lens is becoming difficult or more expensive.
Wonderful.
No, I don't think you should worry about more expensive, because this technique, according to me, will replace all the 3Ps going in there. So this is much easier, much lesser learning curve, etc., etc., etc. Even you can think ahead, the guys who are making the lens, nowadays they make toric IOLs only in a horizontal plane. So in the future, you can make this so much advanced that even toricity can be removed because it can be made in a horizontal plane. Only thing here, one thing, as you mentioned, that vitrectomy is necessary. So you can't have a bag sitting there. So all these cases should never have a bag or any part of the phonics of the bag sitting there. So that is one more take-home message, I guess, you have to give with this kind of IOL.
Yes, sir.
I think all glued IOLs, SF IOL, all the bag, the cortical remnants, everything has to be cleared up. The anterior vitrectomy, use tricot for that, and make sure that your entire that pupillary area and also the sulcus area is completely clear before you insert these lenses.
Nivean, the only way you can kind of make your design more flexible for all sizes of the eyes is to have a concept like the ties we have for the plastic ties we have for shopping bags, or even for electrical wires and things. That we use those ties, which have those serrated things, and they lock in when you pull.
So adjust the size of the.
Yes, so to adjust that, so something which is a non-return, it's a kind of you pull it once and it just kind of, but that will become very cumbersome because this is just some food for thought, because the external part will again have to be adjusted, but that's the only way you can have it adjustable. You have to give the user the adjustability that they can for different sizes of eyes. For the sulcus to sulcus diameter is going to vary.
Yes, sir.
So for that, you'll have to have some, because you cannot keep making, the inventory becomes too huge.
Yes.
And these are not something which you're going to be using every day.
Yes, sir.
So this is going to be a backup. So people cannot keep so much of inventory, and you cannot plan a PC rent.
Only the myopes becomes a problem. The extreme hyperopes, remaining all can be managed with
yes, sir.
this lens.
As Venkatesh sir said, even I had crisis because when I launched it is when the COVID time started. So there was not much of usage, but happy that this year, at least across India, we have almost done 200 implants. So we're trying to collect the data and see what other things or any other modifications that can be done, and to also see how the results are on a long-term basis.
So this is commercially sold?
Yes, sir. Now it's available.
Yes, it's available.
By Appasamy.
Appasamy.
Okay. With your name?
CMT Flex, sir.
CMT, you know what CM stands for? Kumar.
Yeah.
Shalini Madhi. Yeah, Shalini Madhi.
Nivean,
That is a passport also to get a free lens.
Yes, sir. It will be delivered by this week.
No, I'm just kidding.
Sir.
Nivean, one last question. I think it's time to finish also. Now, thinking of the flange technique, looks really great now and very simple than even fixing with the sclera. I mean, will you think T-flex in a different way when you see the flange technique today?
Whether we can make different haptics, like a
the suture, and then you just flange it and push it.
Actually, with a hydrophilic material, you can have it pre-flanged and pull it through, because the hydrophilic will stretch.
It's like that only.
It's stretched
after that.
Yeah.
What is having T is like that, a pre-flange. Because it's almost like a pre-flange. What is this one? The flange technique advantage is very thin, and you can use, if you want to flatten or during surgery create a flange, then you have to use only PMMA material or Prolene. Here it's a one-piece hydrophilic. We cannot use it. You cannot heat it and make it. But a flange technique, the tilt is not in everybody's hands. Most of the people, almost 60% of the implants, they are having some unacceptable tilt and astigmatism in flange technique.
How's the tilt over here? Nivean?
Tilt is almost nil. I think it's
yes, sir,
because it's got a T.
0-180 marking is appropriate. I think if you go a little off that, then there can be a tilt. It depends on the 0-180.
I think slightly broader fixation. No, I think tilt will be very less. Yeah.